Pediatric ophthalmology is actually very hyper-specialized. So we're only going to graze the surface of the diseases, and we're going to stick to the stuff you have to know when it comes to peds ophtho. What I want to start with is the danger of dealing with pediatric eyes. That is to say, if the brain doesn't think the eye is doing what it's supposed to do, it's going to turn off those cortical inputs. The disease state is amblyopia. In which case, you develop cortical blindness. And it makes sense. You've got two eyes. And if the brain is receiving two different images, it's going to decide which one it wants and just turn off the other one. The way you get here is either going to be through strabismus or congenital cataracts. And we'll talk more about these in just a minute. The idea is that this happens only during development. So if you get cataracts later on in life, it's not going to turn off the cortical inputs. It's only as the brain is developing. So you have to keep both eyes working. The problem is it's cortical blindness. It happens at the brain. So once it's done, it's done. There is no diagnostic step. It's a clinical diagnosis if it happens, and there's nothing to be done for it once it's done. But you certainly can prevent it. You prevent it by correcting the underlying illness. And you never let it happen in the first place. So one of the ways you can get amblyopia is with strabismus. It's a hard to say word. It basically means the lazy eye. And you've probably seen people with this condition. What you're going to see on the test is you're going to see a picture of a kid, and you're going to be shining a light on their eye. Now, it is not going to be as extreme as I'm going to draw it, but I want to give you an idea of what you're looking for. The lazy eye is looking way off to the side. And now obviously it's not going to be this extreme, but if you shine a light on this eye, what should happen is the light should touch the pupil at exactly the same spot. But in this case, the lazy eye is way off to the left. So you can see very clearly, clinically, that the person has this disorder. And remember, if we don't fix it, you're going to end up with cortical blindness. So how do you treat it? Congenital disease is generally fixed with surgery, and it needs to be fixed by 6 months. Acquired disease, you have a little bit more time to stay and play. And what you can do here is you can patch the good eye, let the bad eye catch up, or if this is a refractory problem, just get the kid glasses. The other major way of getting amblyopia is cataracts. These are congenital cataracts. And there's two ways of getting congenital cataracts. If the baby is born with them, that is, they are there at the time of birth, this was a torch infection. If they weren't there at the day of birth, but quickly developed, you're looking at an inborn error of metabolism like galactosemia. In this particular case, the sorbitol pathway pushes sugar in developing these cataracts. Now, when you see a cataract, it's there, right? You just look at their eye in the newborn nursery and you'll see it. It's going to be the cloudy or milky white thing in the front of the eye. See why this becomes relevant in just a second. The diagnosis is clinical, you see it, and cataracts can simply be removed. But when you think of white thing in the eye, there's more than just cataracts. Cataracts can be the milky thing in the front, but if you see in the newborn nursery a deep white thing in the back of the eye, now you're talking about retinoblastoma. Retinoblastoma is associated with the, not surprising, retinoblastoma gene. The patient, instead of having the red reflex, that's what you're looking for in the newborn nursery when you shine a light into the back of their eye. You expect your light to bounce off the retina and show you red. But instead of a red reflex, what you have is a all-white retina. The diagnosis is clinical. You look back there and see it. And the treatment is surgical. Now, you may be tempted to use radiation. Don't do that. That's going to be the second hit for the other eye, and you're going to actually induce a tumor there, and the person won't have any eyes because you have to actually take out the entire eye here for the retinoblastoma. And in addition, not only do they have an eye missing, but right around puberty is when they need to start worrying about osteosarcoma. Osteosarcoma is a bone tumor associated with the retinoblastoma gene. All right, we haven't talked about prematurity yet. There is a disease called retinopathy of prematurity. And we know that one of the big things about a premature infant is that when they come out too soon, their lungs aren't ready. So if you have a preemie trying to survive the neonatal intensive care unit and their lungs don't work because they don't have enough surfactant, the only way to keep them oxygenated is to give them high levels of FiO2. Now, too much of anything is a bad thing, and that high level of FiO2 can lead to problems with the eye. And so what's going to happen is if you look in the back of the eye, you're going to see these growths on the retina. And you're actively looking for them. You know you have to give this preemie a lot of oxygen, so you're looking for these lesions because the diagnosis is clinical. And you'll be able to simply take a laser and try to ablate them away. But anytime you see one of these four diseases, you should at least consider the other three. That is to say, the diseases of the premature infant, retinopathy of prematurity is one of them, which stems from bronchopulmonary dysplasia. Not much you can do about that one, but keep up the FiO2. Then you need to consider things like the intraventricular hemorrhage, assess that with an ultrasound with Doppler, and don't forget about necrotizing enterocolitis, which can present with a bloody bowel movement, and the patient needs to go NPO. Now, the biggest thing you can take from this lecture, which is probably what you're going to get most of your peds optho questions on, is neonatal conjunctivitis. And this has changed so much in the past 10 years. It's really important you stay on top of it because the test is going to be up to date. There's really three types of conjunctivitis you care about. There's many that exist, but the ones you want to be familiar with are going to be chemical, gonorrhea, and chlamydia. Yes, there's herpes, and yes, there's other bacteria that can cause this, but it's the vertical transmission of the STDs that matter the most. Gonorrhea because it can destroy an eye very quickly, and chlamydia because it can be indicative of a systemic illness, and it's hard to prevent chlamydia. Now, ideally, we would know that mom has these STDs, they've gotten screened, and we just treat her before baby comes out. But if we didn't, on baby's way out, it can be exposed to these STDs. Good news is that they are treatable with antibiotics. And we want to compare these in relation to their timing, that is the onset, what type of discharge they have, and what you can do about it in the way of treatment. Chemical conjunctivitis specifically means silver nitrate. And silver nitrate was used a lot because we thought it prevented chlamydial vertical transmission. Turns out it doesn't. And so we're giving babies silver nitrate, which just burns their eyes and hurts a lot. The onset is within 24 hours. And because we are applying it to both eyes, and that's what's causing the conjunctivitis, you're going to see a bilateral lesion, and it is going to be non-purulent. The treatment is to not do that anymore. Instead of using silver nitrate, what we should be using is topical erythromycin. Now you can also use a tetracycline in its place, but erythromycin is actually very good at prophylaxing against gonorrhea and non-gonorrhea, non-chlamydia. So basically, topical erythromycin doesn't cause chemical conjunctivitis, and it takes care of everything except chlamydia. Now, even if you do prophylax against it, there is a possibility that you can get gonorrhea. And gonorrhea typically presents at day 2 to 7. And here, it's very obvious. It is going to be bilateral, and it is going to be purulent. It is very aggressive and can destroy an eye quickly. You want to prophylax against it using topical erythromycin. But it's possible that you end up with this anyway. So if you see purulence, you don't know what it is, just presume it's gonorrhea, because gonorrhea can lead to blindness, and treat the gonorrhea with ceftriaxone. You do want to get a hold of cultures, or at least PCR, to make sure you know what you're treating. Gonorrhea needs to be grown on the chocolate agar, and you can get a PCR. Either way, you're going to treat the baby as though they have gonorrhea until the culture of the PCR proves that they don't. Chlamydia cannot have any prophylaxis. We don't have any way of reducing vertical transmission. And chlamydia is going to rear its head around 5 to 14 days. Chlamydia is going to be a little weird. It starts off as unilateral, and it's going to be mostly mucoid, but then turn purulent. And the unilateral eye is going to turn bilateral. The way you treat that is with erythromycin, but erythromycin orally. And if you develop chlamydial conjunctivitis, you need to go looking for systemic illness, specifically looking at pneumonia. Now, there's some other stuff. We're not really going to talk about it. Herpes, we know that acyclovir and galcyclovir can reduce the duration. So just know that from an STD standpoint. And when it comes to the antibacterials, we're going to get a culture, right? We're getting a chocolate agar for gonorrhea. We're getting a PCR for gonorrhea. We're going to grow regular cultures for chlamydia and a PCR for chlamydia. And if we're wrong, it's not gonorrhea or chlamydia, we're going to have cultures and sensitivities that are going to direct what we do. And it turns out that most other bacterial infections that are non-gonorrheal, non-chlamydial are going to appear at day 5 to 14. So we're going to treat them presumptively for gonorrhea and chlamydia, and then wait for those cultures to come back to take care of everything else. All right, drive-by, cortical blindness, prevent it by fixing strabismus and congenital cataracts. You can patch the good eye or give them glasses. If it's acquired, if it's congenital, fix it with surgery. If the cataracts are there, simply remove them, milky white stuff in the front of the eye. Don't be confused with retinoblastoma, which is the white thing at the back of the eye, where you need to remove the eye and be on alert for osteosarcoma. Retinopathy of prematurity, you're expecting it because you're giving that neonate lots of oxygen, ablate the lesions, but also keep your mind open for the other diseases of prematurity. And then running through neonatal conjunctivitis, what you want to see is we don't use silver nitrate anymore because that caused chemical conjunctivitis, and it wasn't very good at doing what we thought it was doing, which is preventing chlamydia. It doesn't work. So now we do prophylax against bacterial conjunctivitis with topical erythromycin, which should not cause the chemical conjunctivitis. If you have a nasty purulent lesion at day 2 to 7, treat with ceftriaxone, presumptively being gonorrhea, but send it off on a chocolate plate, a regular plate, and send for PCR. You want to know if it's gonorrhea. If chlamydia shows up, generally day 5 to 14, unilateral becomes bilateral, starts mostly non-purulent, becomes purulent, you want to treat with oral erythromycin and look for systemic disease. And then keep in mind that whenever you have suspicion for bacterial conjunctivitis, you're going to be growing a culture, so whatever that culture ends up being, if it's not gonorrhea or chlamydia, then you can choose based on sensitivities. And oh, by the way, HSV, acyclovir. That's Peds Ophtho.